Okay, good day, everyone. Welcome to the ASPA FLEX webinar. So, let me introduce myself. I am Dr. Mari Chubatat, your webinar lead. I am a senior consultant in the section of pediatric anesthesia, having retired as department manager for the surgical services department at the Philippine Children's Medical Center. Currently, I am a member of the Committee on Promotions, Appointments, and Renewal of Consultants at the Philippine Children's Medical Center. I am also the chair of Pediatric Anesthesia Council of the Philippine Children's Medical Center, Philippine Board of Anesthesiologists. Joining me as my webinar co-lead is Dr. Rosalie Ponde, President-elect of the ASPA. Dr. Ponde is the Director of the Children's Anesthesia Services in Mumbai and the Program Head of the World Federation of Societies of Anesthesiologists, Academy of Regional Anesthesia in India. She is the lead for the WFSA, CAS, and ISA Pediatric Regional Anesthesia Fellowships. Dr. Ponde is also a member of the Education Committee of the WFSA Pediatric Anesthesia and the ASPA Education Lead. And together we are privileged to present a webinar on the critical lifelines, role of the pediatric anesthesiologist in operating room disasters. Today's ASPA FLEX will be an engaging forum to exchange ideas regarding role of the pediatric anesthesiologist in operating room disasters. This highly interactive session presents cases, scenarios that will provide an opportunity to share experiences and address issues of disaster management regarding fire and flash floods. So before we start the session, I would like to inform everyone of our house rules. For the Q&A session, send in your questions and comments via the Q&A section. Chat and raise hands functions are disabled. Our moderators will highlight our questions to the appropriate speaker during the panel discussion. Some questions will be answered by text with appropriate speaker in the Q&A section. Certificate of attendance will be automatically generated and forwarded to those who submitted the post-webinar survey. The webinar survey will be emailed tomorrow, November 18 at 5 p.m. Singapore time. Please ensure that you have correctly keyed in your full name and email. Disclaimer, note that the information presented in this webinar is intended for educational purposes only and is not meant to be substitute for professional medical advice, diagnosis, or treatment. The views expressed in this presentation are those of the presenter and do not necessarily reflect the opinion or policies of any institution or organization with which they are affiliated. Additionally, the information presented may not be applicable to all individuals or institutions. So if you have missed the past lectures, they can be relayed or viewed in the following ASPA platforms. Through the ASPA website, https://aspa2000.com, or you can like us on Facebook, search for ASPA 2000, or follow us via YouTube ASPA FLEX. So please visit, like, and follow us. Okay. Without further ado, I would like to give the floor to our moderator for the session, Fire in the Operating Room Theater, Dr. Rosalie Ponde, to introduce our panelists. Okay, Dr. Ponde, please take the floor from here.
Many thanks, Maruchi, my friend. I'm extremely eager and excited to get this ahead now. Prior to plunging into this scenario, well, let me give you a couple of newses. Yes, we have had certain mini disasters here itself prior to getting here. To begin with, I am not Vaibhavi. I am Rosalie. Vaibhavi was supposed to anchor the whole show here. However, she is down with fever and recovering, so I'm taking ahead. And having said that, Mentimeter was her forte, which is not applicable here right now. But your vibes are very important to ASPA FLEX. So please put your opinions or thoughts in one word when we direct the question to you as the webinar proceeds. Another one is Hisu, who was supposed to be a moderator and a panelist as well, couldn't make it due to the overhaul in her itinerary to travel. So that is what it is. She's somewhere up in the air currently. So Vibha is going to pick up that job and she's going to multitask as our IT specialist as well as the moderator in this particular scene. Well, having said that, let's come to the scenario. The scenario is fire in the operation theater, my friends. Ponder on fire. It's important to understand this. Fire is a power that we have in the nature, isn't it? The same power, the same fire is cooking our food and the same fire can burn our forests and cities. What if that fire happens in the operating room? What if that fire from the operating room goes to the entire hospital and the premise and just the vice versa? So when we understand how to manage fire in one location, we understand how to manage fire overall, perhaps by application of the same principles. We are going to go to the details of it by quizzing our panelists and looking at a scenario. So our panelists are Dr. Gozen. So she is one of the most apt panelists. Soon you shall know why. She is an associate professor, chairman of Medical Skill Training Commission. She is in Kahramanmaraş University Hospital. That's where she works. I've tried my best to pronounce it. Republic of Turkey Ministry of Health Neonatal Resuscitation Trainer as well. She is a member of Turkish Society of Anesthesia and Reanimation. Most importantly, disaster and trauma anesthesia. She's the vice president of that. Regional Anesthesia Committee member, Turkish Society of Regional Anesthesia as well. Coming to Vibhavari Nai, we call her fondly Vibha, which you must have noted by now. She's a senior consultant in the Indo-American Cancer Center and Research Institute, Hyderabad, India. She's a secretary of ASPA currently, past treasurer, Indian Association of Paediatric Anesthesiologists, Pediatric Anesthesia Fellowship, IAPA, she runs one. Onco Anesthesia Fellowship, that's another one that she works into and is a mentor there. She's a vice president, Indian Association of Vital Anesthesia Simulation Training. So yes, her special interest is pediatric onco anesthesia and vascular accesses. So these are the two brilliant panelists that we have. Let's watch a movie right now. How about that? So here is an adolescent. They all are so conscious about the warts and the moles on their face and neck. So this is what this patient is here for. We have given a MAC and he is under nasal prong oxygen. And this is what is going to happen. This is the removal. And the surgeon has checked with the anesthesiologist, marked, and then watch for what is happening. He picks up a cautery and tries to incise, and then lo and behold, fire erupts. Now, if something of that kind happens, what do? Panicking is not a luxury that we have. So we should be getting into preventions and preparations. So let's get on with the with actually what the emotion is like when something of this kind actually explodes in front of us. I would really love the audience to put in the Q&As to understand what they have gone through. If I could get it, I would be glad. Well, moving further, it's kind of a situation which obviously is not very common. So I'm sure that's kind of a panic, scare, and worry. Well, so what would be our first response? Actually, a race mnemonic would really sum it up. First is we should think of rescue. Alarm, of course, almost simultaneously. how to contain what has erupted in front of us, and how to extinguish so that it is nullified. Shock and panic is one of the expected answers that we have got. And yes, Jayanti, that's so true. You have probably just summed it up. So let's go to the question for our panelists, who all are informed in code red, Dr. Gozen. And having said that, Dr. Gozen herself has experienced an earthquake yesterday where she lives. So yes, over to you, Dr. Gozen.
Thank you, Vushali, for your nice presentation. And I think it's a good start for talking about red code. We need a quick and organized response to the fire, ensure everyone's safety. A red code is an emergency alarm and indicating a fire or potential fire within hospital. A red code number can be different each hospitals. In a red code situation, we need to inform several key personnel. In each hospital, various tasks may be assigned different personnel. If we talk about which personnel should be called or informed in general, first, fire safety officer will assess the situation and determine whether to contain, extinguish, or evacuate. The fire extinguishing team who will handle the immediate response. Then the security needs to be alert as well to manage the area. And then the security, the electricians who can address any electrical hazards. We also have the oxygen and gas source controller to ensure safety regarding oxygen supplies. The water hose controller must be informed and facilitate any firefighting efforts. And finally, the medical director should be notified to oversee the overall response. These are the teams we should give information quickly during fire. If there is a team or person I haven't mentioned that you need to inform specific for your hospital, you can add them.
All right, yes, it's a very, very clear picture of what it happens. Then maybe while I was listening to your lecture, a thought just crossed my mind. Maybe I should know who the fire officer in my hospital is rather. So Gozan, one more question to you. What are the high risk situations for fire inside the operation theater?
Yes. Knowing high risk situation for the fire is the first step preventing fire. If we talk about these high risk situations, fires occurs when ignition source, fuels, and oxygen come together. Examples of fuels include alcohol-based skin antiseptic, surgical drapes, gowns, nasal cannulas, masks, and even patients, gastrointestinal gas, air, adipose, tissue. Ignition sources include electrosurgical device, powered surgical instruments. Example, drills, burns, saws, fiber optic light cores, and lasers, and defibrillators. Oxygen enriched is the most significant factors contributing to surgical fires. Nitrous oxide is as dangerous as oxygen is supporting fires. Approximately 75% of the operating room fires occur when there is an oxygen-rich environment. One significant risk arises from administering a high concentration of oxygen over the 30% for awake patients. During heat, face, and neck surgery, oxygen is usually given by open source, such as nasal cannula. When oxygen concentration is increased in the surgical phase, fire risk is increased. Surgical procedures performed above the xiphoid process and orifice carry the greatest risk. And these surgeries, including lesion removal on the head, neck, face, tonsillectomy, tracheostomy, burr surgery, removal of the laryngeal papillomas. And second, electrocautery counts for 70% of the operating room fires incidents, with the other source like lasers, light source, and defibrillators. Also material like drapes and prepping agents, especially alcohol-based solutions, and when oxygen is present, can cause operating room fire. Using waterproof disable flammable covers and not waiting the alcohol-based solution to dry sufficiently poses a risk. These are high-risk situations. Do you want to add these situations?
All right, well, that's clarity. So let us all ponder, audience who are watching us, which type of fire extinguisher is kept in the critical area like OT and ICU in your working premise? Maybe if you know, you can put it up. And this question actually made me wonder a couple of days back, what exactly is the make that I have in my OT? So any feedback we would love to hear. However, these are the types of fire extinguisher we know of: water, dry powder, foam, carbon dioxide, and wet chemicals. So yes, we've gotten one feedback from Ong, carbon dioxide. Yes, so that's one of the things that are listed here. So these are the, remember, there is not one type, there are many. So we must get acquainted with them, whichever type we have. So here is a typical type, which is now going to be shown, and we shall just quickly go through what it is like, how to use a fire extinguisher. Having said that, please remember, it may not be the one which you have. So there is this pull safety pin in each one of them. We need to squeeze the lever, aim at the base of the fire, and sweep sideways to extinguish the fire. So understand the fire extinguisher which is closest to you in your premise. So now, since we've gathered so much, let's understand what are the preventive measures to avoid fire hazards in the OT in the first place. And Vibha is going to put a lot of light on this. Over to you, Vibha.
Hi, thank you, Vishali. So I'm going to take back the thought process again to what Dr. Gozan was telling us, and that is about what are the high-risk situations. So the first step should be to identify which procedures or which situations are going to be high risk and to include the fire safety while performing timeout for these procedures. And this would mean paying particular attention to avoid pooling of alcohol-based skin preparation and allowing adequate drying time. Now, one of the ways that this can be achieved is that patient is painted first and then the nurse goes to scrub. That automatically gives time so that there is adequate drying of the solution. Dr. Gozan also mentioned reducing the oxygen availability at the surgical site to less than 30%. So the example that you have given, I think with nasal prongs, we need to ensure that the oxygen needs to be dialed down to less than 30% and as low as it can be, provided the saturations are holding above 94%. Avoiding accumulation of oxygen under the drapes is again important, and this can be avoided by an open draping system rather than using a whole towel. Many of us use whole towel for smaller procedures, but that should be avoided and an open drape system should be used. And using a lot of wet gauze in the surgical area to begin with, and the surgeon announcing the initiation of cautery use. These are some of the things that have been mentioned in the fire prevention algorithm by Anesthesia Patient Safety Foundation.
Vibha, any particular thought on which cautery would be better?
So normally, initially, monopolar cautery is used, which is actually a high risk. I mean, when they start, but once they open, they go on to bipolar, and the incidence of the risk of fire is less with bipolar cautery.
All right. And you have put in a good thought of extra saline bottles handy so that we can just splash saline over the area which has suddenly shown us fires. And okay, now there is a good feedback here from Narayanan. Skin preparation solutions like chlorhexidine responsible for burn injury in surgical patients, a little more, of course, and using Iodine solution for skin preparation may help avoid burns, but it might burn the skin. So beware of what percentage of iodine we use, especially on small children. So now that Vibha has told us how to look into prevention, if the fire has really indeed on and is now gripping, so how do we prioritize evacuation? That's the first thing we need to understand. So over to you, Gozen, again. Please tell us.
In the event of a fire operating room, the primacy order for evacuation and precautions to be taken extremely important. First, the fire safety officer assess the fire situation and takes necessary actions, then try to control, extinguish the fire. But if this is not possible, they initiate the evacuation. It is important to avoid using elevators during a fire. Instead, use stairs and designed emergency exit routes to ensure safety. During evacuation, the ambu bag and necessary emergency medication should be carried. People closest to fire should be evacuated first, and second, patients and staff who can move independently should be evacuated quickly. Then patients and staff who need assistance should be next priority. Under anesthesia, patients should be discharged, but surgical closure should be expedited, and necessary support units should be transferred. In general, the primacy of our evacuation is as follows.
All right. Yes, that was kind of picking up all ends together. I am just wondering, what happens to the person who is evacuating? Is there any way they can actually wear something protective? The way we had our PE eased when we handled COVID? Or it's just that they should take a route where the fire has not engulfed the area, maybe. So you said don't go by the lifts and maybe. Okay.
So fire,
I just
sorry,
got a
may
wave
I?
of empathy towards the person who's evacuating also,
So fire safe materials are available.
Yes.
But I'm not sure whether the firemen have it. I'm sure they have it. And we do not stock it in our hospital as a fire safety team
Yes.
thing. So maybe this is something that can be looked into and made available for the fire safety team of the hospital.
Yeah. Sure.
Yeah.
So Vibha, now that you are here with us, the question is getting directed to you. What are the modes of moving the patients and where would you want to move them?
Okay. So being anesthesiologist, I think it's the most challenging part of moving patients because most of our patients are sedated or anesthetized or sometimes even critically ill if they are in the ICU. So typically what we use for moving a patient is a patient shifting trolley. But if the fire is large and if many patients are required to be shifted, fire safety trolley is the patient shifting trolley is not, the numbers are not going to be adequate. Also, the patient shifting trolley is useful only whenever there is horizontal evacuation, which means on the same floor, you're moving across. Vertical evacuation is actually difficult unless you have this fire exit ramp. So fire exit can be a staircase or it can be a ramp, and only ramps will allow using patient safety trolley because staircase, it's going to be extremely difficult. The other alternative is to use a trauma spine board if it's available, where well, our fire safety team stocks the portable foldable stretchers. So this is something that can be extremely useful in shifting patients for vertical evacuation. If nothing is available on hand, then probably using a blanket or a doubled up bed sheet can be used to carry the patient. However, we need to remember that as anesthesiologists, we have to be in control of the airway. So if required, probably secure the airway before shifting the patient and carry the emergency drugs like Dr. Gozain mentioned.
Okay.
Oh, the second part you asked me was where do we shift
Yes.
these patients? So I think for each hospital, there should be a emergency escape route, and I've put one from my hospital. As you can see, so every floor is going to have this escape plan. There are red bold arrows that describe where you need to move to the nearest fire escape. There is a green triangle that shows where you are at that moment. And this map also shows the fire extinguishers that are available on the floor, mentioning the type of the extinguisher also, because depending on the type of the fire, the type of the extinguisher that you would want to use would change. So where to shift this patient? Actually, the fire safety officer needs to decide, depending on the size of the fire and the risk of spread, whether he is planning just a local limitation and horizontal evacuation, or the fire is going to spread more and vertical evacuation, sorry. So the safest area in smaller fires would be the pre-op, post-op holding areas. If required, moving to another building, then probably an intensive care area or an emergency room, whatever is available can be used. But if the fire is large, increasing fast, and then you need to evacuate the entire building, another hospital, then assembly points are created in the parking area of the hospital where you need to assemble. So probably these are some of my thoughts on this.
Yes. Yeah, clear as crystal. So maybe we all need to understand what we have discussed here. Maybe these are points to take home and realize what are our pathways when it comes to fire. Probably I had not paid attention much to all these aspects before we came here and discussed all this ourselves. So, well, this is what it could be when fire really erupts in our working premise, wherever it is ICU or floors or OT. So this is what happens. And well, let's conceptualize certain take-home messages after this. Don't forget that there is a fire alarm for code red. Before that, this webinar would have told you how to prevent, because prevention still puts you in a far better situation than knowing how to handle a situation. So, well, prevention is better than cure. Understand the fire alarm system. Get acquainted with the fire extinguisher in your hospital. Please remember, if you're going to various hospitals, they're going to be different perhaps. Evacuation plans need to be understood. Mock drills need to be conducted so that we are all on the same page if at all disasters ever strike and they don't tell us and strike. Prevention of surgical fires. We have understood what really increases them. So I think the last point on the list must come the first, and that's what we did right now. So risk and safety techniques have to be understood and executed. And I guess as an entire team, we all should be aware of it. So amongst many other things that an anesthesiologist needs to be aware of, this is one additional thing. Well, having said this, let me do another pleasant responsibility. We fired it, now let's go and flood it. So we are looking into another scenario of flash floods. Let me introduce the pleasant responsibility of introducing Dr. Sarpil Ozen and Dr. Teddy Fabila and the panelists. Sarpil is a dear friend, of course, and she's an associate professor, Department of Anesthesia and Reanimation, University of MAA Asadabem, Istanbul, Turkey. She's a president of ASPA. She's a member of Educational Committee of ASPA. She's a member and chair of Scientific Committee of Paediatric Anesthesia of Turkish Society of Anesthesiology and Reanimation, chair of Paediatric Anesthesia Committee and council member of WFSA, and she's an honorary president of Society of Anesthesia Technicians of Turkey. And her interests are, of course, pediatric regional anesthesia and TIVA, fluids. Well, her interests span a wide horizon. And our next moderator is Dr. Teddy Fabila. She's a resident physician, Department of Pediatric Anesthesia, KK, Women's and Children Hospital, Singapore. You would soon know how vibrant he is and extremely articulate. He's a visiting consultant, Philippines Children's Medical Center, and co-lead of KKH Pediatric Pain Committee, KKH Management of Information, Hospital Quality and Safety Standards, KKH Division of Surgery, Medical Informatics, ACP, Singh Health Associate in Education, member ASPA and PSPA. Special interest, of course, pediatric anesthesia, pain in children, hospital quality and safety standards, medical informatics and education. So over to you, two moderators, and we are going to sit back and understand what to do when it floods.
Hi, thank you, Urushari, for the excellent presentation and introduction. I want to introduce again Dr. Marichu Diaz-Batat, who is a dear friend also, and he's a very old. She's a very old member of ASPA. She's a senior consultant at Philippine Children's Medical Center. She is a member of the Committee of the Promotions and Appointments, also Philippine Children's Medical Center, and also head of the Council of Pediatric Anesthesia in Philippines Board of Anaesthesiology. Her interests are anesthesia for children with special needs and also anesthesia for procedures outside the operating room. I want to stress that this disaster webinars has began with her idea. I want to introduce Andy Ade. She's also an old friend. She's a senior consultant and pediatric anesthesiologist and head of the Department of Anesthesiology and Intensive Care in Cipto Mangunkusumo Hospital in Jakarta in Faculty of Medicine of University of Indonesia. She is a former president of Asian Society of Pediatric Anesthesiologists, and also she's a member of Commission on Education in Indonesian Society of Anesthesiology and Intensive Care, and also she is vice chairman at the Indonesian College of Anesthesiology and Intensive Care. She is interested in pediatric liver transplants and conjoined twins, airway management, simulation in medical education, and emergency delirium in children. Now we are going to also present Dr. Duampan Horatarana Ruang as one of our panelists. She's a pediatric anesthesiologist and head of the palliative care medicine department at Queen Sirikit National Institute of Child Health in Thailand. She's also an ASPA member. She's interested in pediatric anesthesia, pain management, and pediatric palliative care and risk management also. Now we'll all have put our thoughts at the flood. When there is a flood in our operating theaters and we are at the operating theater with our flood. And with the flash flood with electrical outage in the operating room. We'll watch our video.
Thank you very much, Dr. Serpil, for that introduction. Before we start our discussion, we just want to ask our audience. I know we understand that flash flood is not common for some other countries. It's specific for certain geographic location. But we wanted to know whether how many from our audience do have in your institution, in your operating some workflow or policy for flash flood management. So we will launch our poll and you'll have 30 seconds to answer. Okay, the poll is up. So if you have, you just tick yes, and if you don't, then just tick no. I think we just wanted to have a full grasp and understanding of our audience when regarding their policies and workflow with regards to flood management. All right, 10 more seconds. Please key in your answers. Almost all of our attendees already key in. All right, okay, so we have 100% of our attendees. Okay, so we will end the poll and share our results. It's interesting to know that 88% of our attendees actually do not have any operating theater workflow or policy for flash flood management. So I think, I hope that this presentation that we are going to share will help you to provide certain ideas and what are the things that we can actually do in the event of flash flood and electrical outrage. Published studies regarding flash floods are scarce and still need to be explored. A flash flood is high intensity and rapid onset caused by heavy rainstorms or sudden release of waters from dams or streams. This evening, we'll be sharing with you a case wherein a 1-year-old undergoing bilateral hemiotomy under general anesthesia combined with epidural in a ground floor of a hospital met this particular scenario. So we have a flash flood, right, during a heavy rainfall, which flooded the hospital grounds and the ambulatory operating room on the ground floor. The flood caused a loss of power to the ground floor, including the ambulatory operating area. So the goal now is to evacuate the patient to the main operating theater on the second floor. The destination was less than around 10 minutes using the hospital ramp. Let's watch the video to better illustrate what's going on.
Let's prepare to come to a higher ground. Prepare the necessary papers for evacuation. Preparing. That's lighting up. Preparing the necessary equipment for transfer. Space. Ready to transfer. 3, 2, transfer. The patient. All monitors ready. Yes, ready. Flashlights ready. Ammo bag ready. Let's move on to the higher ground.
All right, I think the team did quite well preparing and transferring the patient. Now let's move on to answer a couple of questions concerning this scenario. So flood waters entered the operating room. So what are the concerns? So Dr. Marichu, do you mind sharing with us the possible concerns of flood waters?
Okay. First, a prompt decision should be made to move the child out of the ambulatory operating room. Of course, safety of the child and OR personnel is a priority. An identified sterile area on the higher ground to receive the patient and continue the surgery. The operating room staff, including the pediatric surgeon and pediatric anesthesiologist, should also be available. This is another set of staff should be available to receive the child and finish the surgery. Operating room setup for surgery must also be in place before transferring the patient. And there's also a problem of electrical outage. So roles of each OR staff should be carried out efficiently without overlapping of functions during evacuation. Okay, thank you, Teddy. So this is a checklist. Prepare this checklist for the complete loss of electrical power and line during the floods. Okay.
Thank you very much, Dr. Marichu. You mentioned about the key roles of different personnel. So let's now understand what are the roles of each operating room personnel during water flooding in the operating theater. Can I hand over the floor to Dr. Ade? You mind answering the question?
Thank you, Teddy. During the flash flood, operating theater personnel have critical roles in ensuring patient and staff safety and preserving equipment and maintaining continuity of care, and to minimize disruption, safeguard patient care, and protect hospital resources. Each member should respond in a rapid and coordinated manner. The primary priority should focus on safety with patients and staff, and patient care continuity and preservation of essential resources. and the leadership should typically be assumed by someone with both authority and a comprehensive understanding of clinical and operational needs. Here's an outline of the key roles. First, the surgeon. The head surgeon or operating theater supervisor typically has the clinical authority and situational awareness to make quick, informed decisions regarding ongoing surgeries, patient prioritization, and staff safety. And he can quickly determine the most critical cases and prioritize surgeries based on severity and urgency, possibly deferring or non-emergency cases. And he can work closely with anesthetists and nursing staff to coordinate patient transfer or adjustment in surgical plans if necessary. And for the anesthetist, works alongside theater leader to make patient-focused decisions, especially for those under anesthesia or requiring stabilization during transport for evacuation. He can ensure the patients are stable, particularly if surgeries are interrupted or postponed. He can provide necessary sedation or pain control and work with technicians to ensure anesthesia machines are operational if power sources are affected. The anesthetist can maintain and secure a patent airway with non-rebreathing bag and transport ventilator also. In this situation, maintain anesthesia, and we can convert from general endotracheal anesthesia with caudal block to total intravenous anesthesia intubated. And portable cardiac monitor during transport and keep patient dry and thermoregulated. We can maintain sterility of the surgical site, and we should have on hand resuscitation drugs and video laryngoscope with appropriate blade and handle, and age-appropriate endotracheal tubes also. And for the nurses, the scrub nurses will collect and secure essential instrument and supplies in waterproof containers to prevent contamination and help facilitate any quick closure or procedures if surgeries are interrupted by the flood. And we prevent contamination as much as possible. For circulating nurses, they can assist in the same movement of patients within the operating theater or two other safe areas, and liaise with hospital administration and other departments to ensure smooth transfer of patients or resources as needed. And they can also identify any water intrusions and potential electrical hazard in the operating rooms, ensuring quick removal or isolation if necessary. For operating room technician or non-medical personnel, they can ensure critical equipment such as ventilators and monitors are either secured or relocated to avoid flood damage. They can help transition to backup power sources, prepare for cleaning and disinfection of all equipment exposed to floodwater once conditions are safe. And the cleaning staff can work on limiting water spread by setting up barriers, like clearing drains and drying affected areas. And once flooding is under control, disinfect and sanitize operating rooms and recovery areas to prevent contamination and infection. And for personnel from outside the operating theater, they can communicate with emergency response teams, assessing the flood's impact and orchestrating the evacuation of patients or personnel if needed, and keep all operating theater staff updated on flood status, source essential supplies, and additional personnel if required for emergency surgeries or patient support. The security can ensure that only essential personnel enter the operating theater and help transport patients to and from the operating theater. So what should we prioritize for this patient? Like patient safety and stabilization should be our first priority, and staff safety also, and securing essential equipment and supplies. We can maintain communication and coordination, implementing infection control and continuity of patient care.
Thank you very much, Dr. Ade, for that very clear and detailed discussion of the key roles and responsibilities of the personnel and, of course, our primary priorities. Now, you mentioned earlier on about preserving sterility. So can you give us some tips or ideas on how we can actually preserve sterility of the surgical field, particularly if the patient is still ongoing and then we need to transfer everything in a different location?
Thank you, Teddy. Preventing contamination during a flash flood in a hospital is crucial for maintaining patient safety and infection control. Here are several strategies. We should isolate sterile supplies and equipment by relocated away from potential water exposure. You can use waterproof containers and place critical equipment like anesthesia machine and ventilators on elevated platforms. We can limit entry and access by restrict access to the operating rooms and seal doors or entrance that could allow water or contaminants into the operating area. We can implement infection control protocols like use protective equipment, maintain hand hygiene, and dispose of contaminated PPE properly. We can decontaminate surveys and equipment after flood water recedes and ensure proper waste disposal. By taking these steps, can help minimize the risk of contamination. And how do we preserve sterility during transport? We can maintain a sterile environment as much as possible. We can use PPE, contain and cover the patient with sterile barriers and waterproof cover. We can minimize contact with non-sterilized surface and disinfect equipment and surfaces and implement waste management. We can differentiate between clean and contaminated area or pathway during transport and post-transport decontamination.
Thank you very much, Dr. Ade, for that very practical tips for how we can actually maintain or preserve sterility during the transport. Okay, now let's move on to our next issue that we wish to discuss. Fire and electrocution during flooding are the two main concerns, right, during flash floods. So how do we prevent these accidents? Maybe Dr. Marichu, do you mind giving us some tips on preventive measures?
So electrical currents can travel through water, so electrical shock or electrocution can occur. So we should avoid contact with all electrical equipment and taking immediate action to deactivate the power source, unplug all electrical equipment, and shut off and disable operating room circuit breaker. Fully charged emergency wall lamps with battery-powered sources are sustainable in flooding. So one question is, can we use generator to power the operating rooms during flood? So using generator during flood can be hazardous. Generators should only be operated in well-ventilated, dry, and away from any potential water source. Exhaust fumes from generators can contain deadly carbon monoxide. It is best to consult a professional electrician before using generator in flood conditions. Okay, thank you, Teddy.
Thank you very much, Dr. Marichu, for that preventive measures that we can use. And yeah, we cannot use generator unless it is actually approved by our engineer. Now, let's move on to next question. So our next question now, we already have a electrical outage, right? And there's an ongoing procedure. Then how are we going to address this issue? So maybe I can hand over the floor to Dr. Dwenpen. Do you mind answering the question?
Thank you, Teddy. So this is the situation where we have operating room electrical power outage. I would like to spend a little bit time addressing the importance of this issue. It's the critical event because operating room has high technology equipments, and when there is power failure, it will put patients to the risk. And the most common causes are the extreme weather events and regional disasters, such as in this scenario is the flash flood. So then the effects of the electrical outage could have the effect on different aspects, such as lightning loss, the team will have to work in the dark, especially in case of flash flood when the generator cannot be used. And also the loss of electrosurgical unit, the surgeons might have to use different measures to stop bleeding. And also the loss of monitor display, loss of the suction power, loss of the power of anesthesia machine, ventilators. It has to be on battery power. And the compromise of communication because the failure of the communication equipment, such as telephone, pager, or the Wi-Fi, and affects the drug delivery system, such as infusion pump. And we will lose the room temperature and humidity control, which could put the patient at risk of hypothermia, and also affect the logistics, such as the door, the secure door that you have to use Face ID or the badge. And also the elevator cannot be used. But in the case of electrical outage itself, the evacuation might not be the answer in every time, because if it's only the electrical outage, you can wait and for the electrical to come back. But in this case, with the flood, we may need to abort the operation. And for the management of the electrical outage, before we encounter this situation, the emergency situation, the hospital should have the preparedness and the plan for power supply. Usually, the hospital will have the main power supply, the secondary supply from the generator, and also the uninterrupted power supply system. So, hospital should have plan in the hospital level and also the OR and service level. And the staff, every staff should know this plan, and staff education and training is very important. Staff should know their roles, and there should be a liaison person to communicate between teams. For the immediate management, such as this situation, the OT and anesthesia team should have knowledge of battery life of all the equipments they have been using. Then the team should make decision whether to continue the short procedures to make it finish, or if there is no time, they should prepare for the evacuation. And the emergency equipment that they should prepare, including flashlight, the transport monitor or tool for transportation, transport bed, and keep the sterility of surgical sites, such as Dr. Marichu and Dr. Ade had mentioned earlier. So in this case, it is not only electrical outage, it's electrical outage plus flash flood into the first floor. So evacuation is the answer for this situation.
Thank you very much, Dr. Duen Pen. Maybe I will ask Dr. Marichu and Dr. Ade as well. In your institution, right, in your respective countries, do you have a current, let's say, workflow policies? And Dr. Duen Pen mentioned about training earlier on of all the personnel. Do you have it currently in your institution? Maybe we start with Dr. Marichu.
So yes, we have a protocol, but unfortunately, we need more training and simulation so that all the staff will be knowledgeable in how to evacuate or manage these situations when it comes. So
yeah, how about Dr. Ade, Indonesia?
Yes, Teddy. We have mandatory protocols for the hospital disaster plan for every hospital. So whenever they want to ask for accreditation for their hospital, they have to show us the protocols of a hospital disaster plan, including the the fire, the earthquake, and the floods, and also they have to show for the simulation for those three preparedness. So it's like mandatory for the hospital to have it. But in some hospital, like in the bigger hospital, like the OR would not be placed in the first floor. It would be like in the second or the third floor. But in the smaller hospital, then it might be in the first floor. So it is very nice, very useful to have those kind of protocols.
Yeah, it's good that institutional or national accreditation forces each institution or hospital
Yes.
and a proof of training as well in Indonesia.
Yes.
How about Dr. Duen Pen in Thailand?
In my hospital in Bangkok, we only have the protocol for fire, and we train and have practice like event practice every year. But as you may have heard that in Thailand we just had flood in the northern and northeastern part of Thailand just a few months earlier. So I think some hospital they have protocols for national disaster.
Yeah, thank you very much for all your sharing. Now let's move on to our next question. So our next question, right, after all this scenario and after everything is settled and patient has been transported to the main operating theater in level 2, then who will inform the parents, the guardians, regarding this issue and the situation? Dr. Duen Pen, do you mind sharing again?
Yes, Teddy. So we're talking about the communication. The communication, it's a vital component of emergency response, especially in this disaster. So it should be in hospital level, such as the announcement or visual signals to alert the people in the hospital that there is emergency situation. And also communication between the hospital staff to make sure that the plan is triggered and then followed. Everybody is following the protocol. And the important another important issue is the communication with the parents and family, because in this chaotic situation, they might worry about their child. So there should be designated communication officers to ensure the reception and the comprehension of the information we giving to the family. And to coordinate with the receiving unit. In this case, we moving to the higher floor. So there should be a person communicate between the OT team and the receiving unit. And also another communication that is important is the documentation. In this case, we have to use a paper record because the electronic record might be out of work. So the detail of the information that we should give to the patient, to the parents, is that the parents, that the patient's condition is okay and the operation is not finished yet, but the patient will be taken care of. We will transfer their child to another safe place, and we will continue the operation with the doctors and nurses that are also competent as good as the prior team. And also in this case, the parents has to be evacuated also. So there should be a person coordinate the evacuation plan for the parents also.
Yeah, thank you very much, Dr. Duen Pen. Correct, because it's not only our concern that focuses on the patient, but the entire, all the patients, parents, and families as well inside our institution. All right, so moving to our last question. I'm sure that this is, for this particular scenario, right, flash flood, will be quite traumatizing, right? And to some patients and families. So who will deal with the psychological trauma if there's any issue with this? Dr. Marichu?
Okay, thank you, Teddy. So how do the child cope up with psychological trauma? We should always keep an open dialogue with the child, listen and respond in an honest, consistent, and supportive manner. Be reassuring to the child and watch for any physical symptoms like being clingy or unable to sleep. So in this situation, I think we should refer the child to a professional help, like a psychologist or the teacher or the pediatrician. Then for the parents, reassure the parents that their child is well taken care of, and focusing on something practical that parents can do right now to manage the situation better. We could recommend some relaxation methods like listening to music, or other activities that will divert their attention regarding the trauma, regarding the situation. Or we could ask another person to talk to the parents for support. And if this some situations, in some situations, the parents will have a lingering thoughts about the situation. Maybe we could recommend seeking counsel, or maybe professional help. And for the OR personnel or surgical and anesthesia team, there should be a incident stress debriefing within the first 24 or 72 hours, and encourage people to discuss their emotional reactions to the incident. And the hospital or the institution should invest in time for degrees of preparation and training through drills and simulation. Okay, thank you, Teddy.
Thank you very much, Dr. Marichu, Dr. Duen Pen, and Dr. Ade, for sharing your inputs and answering all our questions regarding flash flood in the operating theater. Now I'll hand over the floor to Dr. Serpil for our panel discussion. Thank you very much.
Thank you, Teddy, and thank you for the flood team. This was what we don't want to encounter during our operations, but when we encounter these, we have to be prepared for. We understand from all discussions as a summary. Now we have some questions, and I would like to thank all the panelists for answering these. One of is coming from Dr. Rebecca Jacob. Thank you for asking. She is suggesting what about switching off the oxygen unless the patient is oxygen dependent. I think we have stressed this, but I want to answer this live. So what about our panelists? Vipa, can you answer?
Yeah, so the oxygen needs to be dialed down as long as saturations are holding 94 and above, like we do typically for any other case. And particularly the APSF guidelines mention the FiO2 to be less than 0.3.
Thank you, Vipa. And regarding the skin preparation solutions, chlorhexidine, is it responsible for burn injury in surgical patients, or iodine solutions for skin preparation may have to avoid this disaster? What are your suggestions, Gözden? Or Vipa?
Yeah. So chlorhexidine is a requirement with the current standards because it allows better killing of bacteria as compared to povidone iodine, except for younger children, like probably neonates or younger infants. So chlorhexidine is something that's quite commonly used, and it's always with alcohol. So practically, we are using the alcohol-based skin prep for all our patients, and that's why we need to be careful.
And also, I think better to wait until it's dry and not flood everywhere. Thank you. And also Rebecca again asks, do we always have time to change into fire-safe clothes? Anybody is under fire? Do you search for your fire clothes and wear them? Vipa?
I am, yeah. Yeah, please go ahead because we don't have fire safe clothes in our fire
We don't have
safety team.
also.
Yeah, no.
I think we in the case of fire, we don't have much time to change our clothes. We will focus on our patients at that time. But if we are on the fire expert team, then we can change our clothes and then jump into the fire to not jump into the fire. I mean to try to
Rescue.
try to rescue.
May I add something?
Of course,
Just a thought. It's just a thought. How in an aeroplane, if there is a decrease in oxygen, the mask falls down and the instruction is first wear yours and then help others. So suppose if we have something very easy to put on, I guess we can save more if we don't get into trouble ourselves. Although this is coming from a person who has not seen a fire chief. I mean, what to put on when there is a fire. So it was just a thought.
To take precautions before we see them. So that's a clever idea. And another thing is that regarding the floods and also maybe the fire, why are all operating theaters are at the bottom floors? So can we suggest the builders that architects to build the in the upper floors for the operating theaters? Yes, Ursheli.
Serpil, the fire people will just say the opposite. Have it as low as this so that they can, from the OR, you can just simply walk out to, evacuate. So I'm not too sure.
Yeah.
Yeah, but in the country that floods is quite often, then we need to consider those regulation that we will put the OR like in the second or the third floor. Like mostly in Indonesia, in the bigger hospital, the OR is in the second or the third floor or even higher. But for the smaller hospital, then it should be in the first floor. Then that could be damaged by the flood because we have a lot of floods here.
And you said that at the beginning of the webinar that Indonesia is a supermarket of disasters.
Yes,
You can't you have to be.
Yeah.
Sorry for that. And
another question, Dr.
Yes,
Serpil.
yes,
I think
Teddy.
this is regarding transfer of patient in the absence of power and electricity. I think this one I'll hand over to Dr. Duen Pen. I think she discussed about electricity outrage, and they're also asking about the minimum essential personnel in transferring our patient. Who are the key person that needs to be involved in the transfer as well? Dr. Duen Pen?
Yes, thank you. So for the power failure, you will be working in the dark. So the recommended set of emergency equipment for the power failure, including the flashlight or the headlight, which has battery on. So there was some scenario case study with the power failure that this emergency lighting is the responsibility for a certain member of the team, such as in one hospital, they put this into the head of the OT nurse. So if there is the code for power failure, this person will get this headlight into the person in each OT, and that person would be, the light for all the team. And then for the questions and this is emphasize the issue that everybody should know their role. And for the team member, I think if it's at the layer of responsibility, right? But if you are the member of the OT team taking care of the patient, so one should do their job like as anesthesiologists we make sure that the patient is safe by having all emergency equipment. We are back into basics, giving oxygen by oxygen tank and, portable delivery system. And also the monitor, that simple small monitor, but have all the battery backup. and also the continuity of the anesthesia that we're giving. Like in the case scenario, we switch from inhalation to TIVA to intravenous anesthesia, and the surgeon team will do their job, covering the wound and stop bleeding. So everybody in the OR is the team member for evacuation, and also the administration officers of the OT would do the communication, the liaison communication, according to the plan of the hospital.
Thank you very much, Dr. Duen Pen, for that. And I think above all, because this disaster comes it's either once a year, twice a year. If we were lucky, it will not happen at all. So I think simulation and training is very, very important for the preparedness of all the personnel. You should know your responsibility, you should know where to stand, and you should know what to do with the event that it happens. So even if you have the protocols or the workflow, if you're not going to practice it, and if you're not going to train your personnel, then it doesn't matter, actually. We have a couple more questions in our Q&A. There's one question here for fire. If the fire breaks out in a hospital and threatens the operating theaters, what procedure should be followed regarding ongoing surgeries? Maybe the question is whether, at what extent are you going to stop the surgery? What's the decision matrix? Is there any type of surgery? If you're doing a cardiac surgery, then what are the steps? Is it dependent on the case complexity or things like that? So maybe I will hand this question to our fire experts. Maybe I start for Biba.
Yeah, hi. I'm sure it's not an easy answer there, because it is the fire safety officer's call whether he has asked for evacuation of the OT. Now, let us assume that there is a fire in the hospital and a code red has been announced. It would be prudent not to start any other cases, beyond that point, or to start summarizing whatever is happening, whether this can be closed, is it okay, are we done? Because there could be a point anticipating that if we need to evacuate. So this could be a thought process before the actual OT evacuation is ordered. But I assume that once OT evacuation is ordered, you just have to dress it up. You may not really have much time to do anything, because often fire spreads faster than one would think. So maybe Vrushali or Dr. Gozen has anything to add in.
You have a certain level. Let's say, for example, in your institution, do you have a prioritization matrix? Who will go in first? Who will go out first? Is it based on the case, or is it based on the operating theater location? Is it if it's closest to the exit or things like that? So in your institution, how do you manage your evacuation system?
So if the fire is in the OT, then the patient that's closest to the fire has to be evacuated first. That's the patient that gets the first chance. And if its fire is not in the OT, then I guess there isn't any specific rule.
Yeah, I agree with Dr. Fiba. Like, if the fire is not on the OT, then we can try as much as possible to isolate the fire, and then try to dim the fire. But if the fire is in the OT, then I agree that we should prioritize the closest patient to the fire, so we have time to evacuate the others.
Yeah, that's why actually the responsibility of the fire warden is very, very important, because they are the one who will be mainly coordinating everything and ensuring proper communication is being translated on the grounds, and all of our end users and all of the involved during the transfer, because they are the one who have an overview of what's going on and where we are going to exit. These instructions must come from one voice rather than too many people giving instructions and everybody is very confused in who to follow. So a fire warden is really very essential during this event. Any other
Oh.
comments or questions?
I want to ask the panelists, do you in your hospitals do in some periods drills or practices of or rehearsing of evacuation or disaster management? Do you have
Yes, Dr. Sarpel, yeah. So I think it is compulsory if we want to continue maintaining the hospital standards of certification. And so it's like every 6 months, a fire safety drill is what is advocated. And we do not have a floods protocol in our hospital.
Same for Singapore. We have our own simulation and fire drill as well. Then on top of that, all new employees or new staff coming in will be given an education. They are mandatory for them to go through this fire and disaster education that under the blackboard, and all MCQs will be answered as well. So it's mandatory, and it's actually promulgated by Joint Commission standards as well.
But can I ask?
Yeah.
Yes,
Do we have drills specifically in the operating room? Yes, we have drills outside of the OR, so the employees just, leave their area and then go down to a specific area where they are supposed to go. But specifically in the operating room, in our hospital, we have a protocol, but we never had a simulation or a drill to evacuate our patients during these scenarios.
Great. And Vushali?
Yeah, I think Vaibhav is not here, who heads a simulation center in a hospital in Pune. I guess what Vibha right now said, that in India, at least all this is a mandatory thing, that, we need certain drills in place to get accreditation, which in other words is a surrogate marker to say that this hospital has certain standards which are in a higher zone. However, a simulation center perhaps would be more appealing, so that all these drills are carried out. And we suddenly hear while we are operating code blue, code red, and we know that the drills are happening around. So yes, that does happen.
And I think we should do that all at our hospitals.
Yes.
Okay. Okay. Any more questions from the panelists or anything to add?
I just wanted to add, if I may, Dr. Sapil. So I think there was a question by Dr. Rebecca regarding the electrical safety. So I just wanted to add that what we discussed predominantly was procedure related fire, but amongst the non-procedure related fires in hospital, electrical short circuit is the commonest. In fact, just a day back, we've had this unfortunate incident of fire breaking out in the neonatal intensive care unit, and we've lost 10 neonates there. So I think the facility safety, electrical facility safety is extremely important, is the responsibility of the hospital and the administration. And in electrical fires, the electricity is switched off. So if that occurs, then again, the operating team needs to take a decision regarding, how to go about. And some of that has already been discussed with the flood team regarding the electrical outage. I just had to add one more thing. I have my the hospital accreditation going on, and just yesterday they announced a mock code red in the air handling unit of the operating room. And this is very special because if there is a fire in the air handling unit, then the way the air moves in the air handling unit, there are two risks. One, it just flared the fire faster, much faster than where it could be in any other place. And the second thing is that the air and the smoke, everything is going to come in the operating room. So though this is at a different level, we kind of had the mock of trying to evacuate in the operating room. So I just wanted to share that.
Yeah. And I also would like to echo what Hong Biao-Chi just shared in our Q&A section. In Singapore, yes, we do. In Singapore hospitals, there is an actual drill and simulation wherein patients and surgeons and nurses, all the personnel involved, they actually push out the trolleys. So it's really a push, and there's a fire warden actually that really act out as a fire warden, and they will really move the patient according to where we're supposed to exit. Yeah. And from here, we really learn a lot, because sometimes what is written is quite good, but when you actualize it, then you will see all of the potential gaps and potential loopholes that you need to close, and you need to iron out the protocol in a practical sense. Yeah. And in creating this escape plan and all that, I think what is best is to customize it according to your institution. There's no hard and fast rule that it must have. You need to identify first what are common causes in your institution, and how do you actually announce it? Who will be the fire warden? And a core group is very, very important. You must have a core group that will drive this initiative from the get-go. And then apart from the core group, you should have an institutionalized auditing system or survey system that will actually counter-check whatever you have created, so that there'll be some sort of review of your current standards. Then it will be clear for everyone and easy to remember. All right. All right. Okay. That's all from me.
And also Rebecca Jacob stresses that not in the hospitals who are preparing themselves for accreditation. In all hospitals, these drills, these practices should be done. Whenever you go for a trip on a boat, the first thing first, before the holiday, they put you on your cameras, and you wear your jackets. Even you are not traveling safely, they do that practice in every trip. So we have to do it if we have an operating theater and if we are caring for children. And I think it's all now. Thank you for Marichu bringing this idea out, so that we can discussing about disasters and saving our patients, little patients from the disasters we'll have. And Urshali, it's over to you to close.
Sure, Serpil. Thank you. So now coming to the overall aspect of this webinar, I hope you all gained from it. I know this is a theoretical discussion, and there is lots that has to be done in a very practical manner. Well, now coming to Asian Society of Pediatric Anesthesia, here is a legacy of 25 years. It's a great news to share with you all that ASPA completes 25 years of serving pediatric anesthesia all over Asia and beyond, in fact. So may it be PPLS, may it be conferences, may it be small workshops, may it be whichever way, wherever an education is needed, ASPA, with all its former people who actually came together and formulated, it's really doing astronomical and very sincere, genuine work. Here is a video dedicated to ASPA's 25th year.
Ta jum num ta rum ta dhalam kutak de gura de tangra de ta jum ta jum ta takita ta ta jum ta tanum ta rum ta takita ta de tangra de ta tarita ta dhanata ta runata ta dimita ta da jum ta tanum ta rum ta gadim takira de ta dim ta tarigida ta jum dim da ta jum nam da ta jum tam takita dhana ta tangira tarigida dim ta tarigida ta jum dim takita jum takita jum ta jum takita ta jum tarigida ta dum tarita ta dhana tarita ta tarigida ta Dhanata jum tarita dhanata de tangira tarigida ta jum dim da ta jum nam da kita jum ta.
So this was just a glimpse of what fun ASPA is, and it's a thick family. So I know the video is beautiful, very tempted to visit it, but we need to go ahead. So ASPA is empowering through education. This is what ASPA is. It's a non-profit organization. ASPA's mission is to foster the highest standard of pediatric care in Asia. Hence, we seek your support to donate and help us in every cause. So it's over to you to think and do this. Well, informing you about our upcoming webinar, please listen to this very carefully. It's about holistic management of pediatric trauma, optimizing airway, blood, regional anesthesia, and post-injury rehabilitation. It's an extremely interesting topic, and mark your dates for that. Well, Sankonan ASPA 2025 in a mystic land of Kathmandu amidst the hills. Please attend this fantastic program, ASPA 2025. So block your dates, 4th and 5th of April. Be there. Promise it would be a good event. So goodbye for now. Have a great evening, and I hope this webinar added a lot to you. Thank you so much. It added a lot to me, of course. Thank you so much. Goodbye.
Thank you.